Hello guys, my name is Della and this is our third video lecture for mechanical ventilation and we're talking about modes. So in our previous video, on the video 2, we left out with the waveform. So we're just going to quickly differentiate pressure versus volume control waveforms. So let's start with pressure for both. So as you can see in here, the pressure and pressure control is more of a square form, and for volume control, it's more of a shark fin. Now, why is it square and pressure control? It's because it's shooting up to going to that set pressure. When the patient takes an inhalation, it's going into that set pressure and staying there for a couple of seconds before cycling off to exhalation. So that's basically giving you more time on having that pressure inside the lungs. As for volume control, the pressure is more of a shark fin because it gradually goes up. So think of it as the roller coaster. You know, when the roller coaster is going up, it's building up that momentum to go into the pressure that the patient needs before it cycles off to exhalation. So that's basically it for pressure. And then I'm not really going to talk about volume because um, it's not, there's not really kind of like any difference between it. Um, so we'll just talk about, we'll skip that and we'll go with the flow. So for flow, for pressure control, it's more of a descending pattern. So think of the flow for pressure control as the roller coaster. After the momentum, it's going down, right? So that going down, that, you know, when you get that feeling of so much like stomach turning and all of those. So that's basically it for flow. It's going down and it's going to a descending pattern. As for volume control, it's more of a square form. So flow and the volume control is more, in a sense, more stable because you're giving that volume, so the flow should, should be stable for a couple of seconds before it cycles off to exhalation. As for flow, it's gonna be more like downhill or like a scoopy because you're not giving that too much volume because the volume varies for the pressure. So that's basically the difference between the two. Now, just, more kind of like of a summarization of what I said earlier in there. So volume control waveform, it's a shark fin pressure and a square flow pattern. So there's a couple of pictures and then there's a picture of a little actual shark fin in the water. Just found it really cute to put in there. And then we got SpongeBob. So in pressure control, it's more of a square waveform in the pressure and then the descending flow for pattern. Now, of course, I'll put SpongeBob in there because SpongeBob is square. So, just kind of cute. Put in there. And then the pressure support CPAP waveform. So, nothing more into it. It's just basically the same as pressure control ventilation waveform. But if you look closely in here, which we can't really do in this point, but when you get the PowerPoint, you'll see there's like a couple of red red in the volume pattern. That means that the patient is triggering that breath. So that red part or chunk in this green flow in there is the patient taking a spontaneous breath. So that's basically it for the waveforms. And we're now shifting gears and going into initial settings. So our initial settings is a tidal volume of 6 to 8 mLs per kilogram. Now that's for patients with normal lungs. And it needs to be calculated from the patient's ideal body weight. Now, I didn't put the calculations on how to do the ideal body weight on this slide. So I'm going to tackle the how to do the ideal body weight towards the end of this lecture. So we set the respiratory rate into 12 to 20, or we could set it in 12 to 18 because those are the normal ranges for respiratory rate. And then I time of 1, beep of 5 to 10, as we said earlier. The normal ranges for the pressure or the peep pressure is 5 to 10. And then the normal minute ventilation is 6. FiO2, my thing is that we could start, you know, at 100 and then just titrate down to what the patient can tolerate. And a trigger of 5. Now this depends on your ventilator. If you're using a ventilator the same as what I use, which is a Servo I, the trigger, the more you go, the higher the number, the less sensitive it is for the patient to trigger or to trigger the breath. If you go lower for Servo I, which is like at 1 or -1 to -2, it's gonna be more easier for patient to trigger that breath. As for other ventilators like Puritan Bennett 840, 980, or a Draeger, they are more going into a higher side. So as I said in here, trigger of 5 will be more easier for patients to trigger the breath. And then for rise, again, this also depends on how the patient is looking and how much comfortness the patient needs from the ventilator. So let's say if the patient is like backing the vent or desynchronizing, we could try and see if we could play with the rise time and see if it'll help. Other than playing with the FiO2, the tidal volume, and the respiratory rate and I time, we can also play with the rise for patient's comfort. So I to E ratio, I put 1 to 1, that's fine, but 1 to 2 is usually the normal. And then pressure support, this depends on the hospital that you're working or depends on the endotracheal size. That's per CHOMP, that's how we do it in the community hospital of Monterey Peninsula, where I do my clinicals. So so that varies. So that depends solely from the hospital protocol that you're working at or doing your clinicals. And then alarms. Make sure that the alarms are not too tight and not too wide. Make sure that it'll alarm you if something is happening for the patient, and do not put it way too tight because if the patient moves, if it's way too close, it could alarm you for just nothing. So just make sure that you set your alarms appropriately. So as I said earlier, all of these initial settings are for a normal lung. So this is like, our kind of like guideline on where to go, for setting up the patient on a ventilator. So that varies depending on the patient's lung severity. So lung severity, lung protected settings. So this lung protected settings is really based on the ARDSNet or for patients with ARDS or anything that has restrictive disease. So tidal volume is going to be more lower than normal. It's going to be 4 to 6. That is in Cairo or book for mechanical ventilation. But for ARDSNet, it's 4 to 8 mLs per kilogram of ideal body weight or predicted body weight. Respiratory rate will be higher. Now, why do we put a higher respiratory rate for these patients? We put a higher respiratory rate for these patients because we are giving a lower tidal volume, lower than normal tidal volume is what I'm saying. So we give them higher respiratory rate to compensate with that volume loss. I to E ratio, so the duration of inspiration should be less than or equal the duration of exhalation. So it'll be the I to E ratio will be good for 1 to 1. So the normal is 1 to 2, but we could put it in 1 to 1, so it's gonna be like equal for both. For FiO2, just enough to maintain the saturations of 88% to 95, because that's where they might be living for as far as saturation. So just titrate your FiO2 based on the saturations, or based on the patient's capacity. And then PEEP, we want it higher than normal. Again, the normal is 5 to 10. So we wanted it to be more higher, around 15 or greater. Now, why is that? We wanted to be higher PEEP because we wanted the alveoli that's previously collapsed to actually open. Now, why are they collapsed in a restrictive condition? Because there's not much volume that's coming in because it's restrictive. So it's more of a stiff lung. So imagine if you're like, hugging yourself or putting an Egan's book in your chest wall and trying to breathe. Now that's kind of like a restrictive because the chest wall is being restricted on expanding. So there's not much volume coming in. So we wanted that higher PEEP to open up those alveoli and to stay, to have them stay open. So the plateau pressure, we want to maintain the plateau pressure below 30. Okay, so just remember that we wanted to maintain the plateau pressure below 30. And this is one of the instances that we allow the patients to be hypercapnic, permissive hypercapnic, or be more acidosis as we speak. We allow that because we don't want to increase too much volume and pop the alveoli open or pop the lung open and create an iatrogenic pneumothorax. That's why we wanted to maintain, we allow permissive hypercapnia to prevent lung injuries. Now, just to kind of go back with the pressure control, now that we're talking about lung protective, pressure control will actually do so well. It's like a gold standard in a sense for a lung protective because it's giving you that constant pressure that's holding the alveoli open, rather the volume support or volume control, which gives you that much volume, because they don't need too much volume, or else we're going to create barotrauma, biotrauma, villi, valley, and volutrauma if happens. So we don't want that to happen. So these are just the ARDSNet protocol. This is the actual ARDSNet protocol, and I just copy pasted this from the ARDSNet protocol because I was having a hard time finding the second page. So just go over those 4 pages of ARDSNet protocol. I put this in here, that way it's more easier access, and it kind of tags along with the lung protective. So not gonna go over those. And then we're here with the ideal body weight. I'm going to talk about this on my next video. Thank you.